I'm Tamara Thomas, editor-in-chief of UrbanHealthToday.com, part of the DocWire family of medical news sites, and I want to thank you for tuning in to Urban Health Weekly. Our goal each week is to keep you informed of the latest in health and medical news right from today's headlines. It's time to empower yourself with open conversations about your medical care with news that matters to you. So are you ready? Let's get started. Welcome to Urban Health Weekly, where we talk about medical news and health topics that matter to you. I'm Tamara Thomas, and I'm here with Lou. How are you?
I'm doing great today. How are you?
Yeah, I'm okay. You sound tired.
Oh, I don't know. I think it's that time of the year where voices are gravelly and all that allergy season.
Oh, that's right. All the
Yeah,
pollen. My car is covered in like a
yeah.
fine coat of like yellow
Fine coat of
green.
green. I have an issue. I do it by the horse races. It starts right before the Kentucky Derby and it ends right after the Belmont Stakes.
Ah, okay, okay. All right.
So for those 4 weeks or 5 weeks, I'm usually miserable as something else blooms.
I do have some allergic reaction, but it depends on the tree. It's not
Yeah.
nearly as severe as it used to be. Like if I'm driving with the window down, I'll get hit depending on what kind of trees it is. And I'm not sure exactly what trees, but I know some trees make me cough and others
Mm.
don't. So I semi understand. You must be miserable right now.
Yeah, I wouldn't call it miserable. But
You
I'm
sound
pretty
like
much
it.
the same way.
What do you mean pretty much the same way?
That different trees and different parts of the allergy season set me off in different ways. So
Ah, well, before we begin, I want to apologize to Lou because he expressed last time that he was unable to get a word in during the obesity segment, and he was absolutely right. But I will personally be more mindful to make a concerted effort to give you an opportunity to jump in going forward.
yep. The videotape showed I had my hand up, I was waving it.
Well, okay, there was no videotape, but duly noted, you did not get a word in edgewise, and the segment suffered for it. So I apologize. And
No
moving
problem.
forward, things are going to be different. I promise. Usually we cover a bevy of topics, but today we're going to keep it light and tight and just cover two topics.
All right.
First, let's talk about what's hot in the news right now. Brazilian butt lifts are the most deadly cosmetic procedure. Listen to this. In surgical circles, the Brazilian butt lift is known as the deadliest aesthetic procedure ever performed, and despite several calls to improve outcomes, recent data suggests mortality is only getting worse, especially in South Florida. Sunny, image-conscious Miami is home to a substantial portion of the country's high-volume, low-cost clinics where U.S. patients flock for the procedure. Despite widely publicized deaths and changes in rules about performing the procedure in Florida, researchers say it's still causing harm. Doctors recently published an analysis of the factors that make South Florida a particularly dangerous place for the BBL, which is also known as gluteal fat grafting. They analyzed 25 BBL deaths resulting from pulmonary fat embolism, where fat globules travel through the bloodstream and cut off circulation. Blocked pulmonary vessels can lead to respiratory failure and death. They found most of the deaths occurred after plastic surgery associations tried to make the procedure safer. Dang. The Brazilian butt lift became popular over the last 2 decades, with procedures surging more than 800% over the last decade alone, according to data from the American Society for Aesthetic Plastic Surgery. During a BBL, a surgeon uses liposuction to remove fat from the abdomen, flanks, or back of an anesthetized patient. The surgeon then uses a syringe attached to a cannula to re-inject or graft the reserved fat into the buttocks. The cannula is inserted repeatedly deep under the skin, fanning out from a few small incision points to distribute the fat across different areas. It's known as a blind procedure, and surgeons can inadvertently injure the large vessels in the muscle or even inject fat directly into those vessels if the cannula goes too deep. The fat can travel via the bloodstream to the heart and lungs, and death from a pulmonary fat embolism can occur within hours of the procedure or even on the operating table. Oh my God. It wasn't until recently that plastic surgeons realized some BBL procedures were going very wrong. While the surgical literature shows that the vast majority of deaths from BBLs occur when a patient suffers a PFE, These events are hard to quantify because of different reporting standards for various state medical examiners. BBL complications are even harder to track because of limited follow-up by clinics that perform them and few state reporting requirements. There's a ton more to this article. I'm kind of skipping around, but I'm going to stop here so we can discuss.
All right. I gotta say, in the article or in the research that I did, there are 81,000 of these a year. So over the next decade, there will be 1 million fake booties out there. That's okay. That's either good or bad. But
did you say fake booties?
Yeah, that's what they are.
Is it technically a fake booty if it's your fat?
Yes. Yes.
Okay. All right.
Because it is not ordained that way. That said, if we add up all the deaths, it's a lot of deaths too.
Well, somewhere I read that at least each doctor in Florida has had at least one death.
Yeah, there's 1 in 3. Every 3,000 procedures, there's 1 death.
That's a lot.
That's a lot of them.
That's an awful lot.
If you start doing the math and you say, okay, over the next 5 or 6 years, we're going to have 1 million of these done. That's a lot of people that passed away. And
for what?
I'll tell you, in the article, they quoted a doctor, and I thought to myself, I don't know, but it kind of makes sense. He said, no one ever died of a skinny butt.
I read that part.
And I kind of tend to agree. I mean, some things, there's a little bit going a bit too far, and I think this goes a bit too far.
Well, no one said that when white women were flocking to get breast implants, but, and I hate to distill this down to race, so I'm going to try to say, maybe making more of a cultural case. And I'm not saying I advocate this procedure, but I can't really poo on the procedure because I myself partake of the lunchtime procedures, etc. I had breast implants put in when I was young, and I had them removed, and I had a breast lift, and so I'm the last one to talk about procedures and enhancements and stuff like that. And I'm not going to sit here and say, well, you have to, deal with what God gave you. But with the advent of the Jennifer Lopez's and the Beyoncé's and the video vixens, the body shape, the ideal body shape. Well, the ideal body shape has always been a curvy woman, but the big butt is what came from. It shifted from the Pam Anderson big boobies to the Jennifer Lopez big behind. And, you listen to rap songs and you watch the videos, and the girls that are most desired, women that are most desired, are the ones with the big round derrieres. So
now it is, but that wasn't the aesthetic maybe 3 or 4 years ago.
That wasn't the national aesthetic, but that has always been the Black and Hispanic aesthetic. Women of different races are starting to get into it.
Look, I've done my research.
It's a huge market.
I did my research. Saying that
it's always been a thing for women of color. It's always been a thing for women of color. But there was really nothing you could do prior to this procedure to get it done, except maybe fly to Brazil, because they pretty much perfected this kind of stuff, the bunda.
Well, there's a lot of stuff that goes over there that I would call non-FDA approved. And med insurance would not cover it here, so obviously the procedure.
But I don't think the procedure so much is the problem as the way that it's being done and marketed. And my issue with it is, and you tell me what your issue with it is. My issue with it is all these quickie doctors and these cheap procedures that are being done 6, 7, 8 times in a day, rotating, with doctors rotating from one room to the next room and to the next room and not focusing. One doctor said that you're not really supposed to do more than 3 of these a day. And you've got some doctors doing as many as 11 of these a day. That's completely unsafe. And that possibly means that the doctor is not the only one working on the patient. That's where you start running into the problem is, you have the lure of get a Brazilian butt lift for for $39.99 or $29.99, meaning $3,000 or $4,000. And you scrape your money together and you fly down there or you take a bus down there and you get it done. And I think that's the bigger issue. But what's your take on this?
Well, my take is that number one, I think this is a temporary aesthetic. These aesthetics come and go.
What do you mean temporary? You only lose about, I think you only lose about 20%.
No, I'm just saying the
trend of it.
The trend of it, the model of beauty.
Well, that's what they said about breast implants, and people
Hey, look,
forget
you know,
those.
I like the classic art, and if you look at Goya and all of that, there was one, you know, they call them the Rubenesque era, and that's because of Rubens. He was the painter that painted all those women. That's why it's called Rubenesque. And you know, they were hefty, then they were skinny in the 70s. Now all of a sudden the ultimate of beauty is the big butt and all this. I think people should just be who they are.
That's very easy to say. You're a man, so it's a slightly different value proposition. And I'm not saying that I would ever do this, but I'm in a different position because I'm happy with my behind. If you're from a culture that values a woman with a shapely behind and you don't have a shapely behind, you feel left out and you feel like maybe your life will be better and you'll feel happier in filling out your jeans. Look, people are not going to stop doing it. They just have to make it safer. And they have to limit how many times a day doctors are allowed to do this. And the reason they're doing it so many times is because they're deep discounting it. And who could resist? I mean, I would never, but who could resist a procedure that's rock bottom price? And this is what's killing people, is that you have to be careful what you pay. You get what you pay for. And unfortunately, if you do this, you're paying with your life. That's what I think the issue is.
Right.
Not so much the procedure. I wouldn't like to see a ban on the procedure, but I would like there to be limits on how many times this procedure can be done per day, per doctor.
Yeah.
Highly supervised, make sure that they're the only one actually doing the work. And you know what? The price is going to go up, and that's okay. And then, you know, less women are going to be able to afford to do it. And I'm kind of okay with that, because I would rather you not afford to do it or save your money and get it done right than to take your life into your hands and leave your family behind and bereft because you want a discount.
I think it's high risk, low return. And to me,
how can you say that? How can you how can you say that about someone's happiness?
I don't know. I mean, you really are happier because you've got a bigger butt. I mean,
some people feel that they will be.
You fill out your cars.
And again, I'm not advocating this. I'm just putting myself in the position of a person who does not feel they have an attractive derriere or attractive figure. And if they can get some lipo and move things around. I'm also worried about the health implications in terms of, you may move this fat around on your body and turn yourself from an apple to a pear, but then does that really change your health on the inside? No, it doesn't. So I worry about that. That's another big thing. I've talked about this before. Okay, so we're going to take a break and we'll be right back.
Great.
And we're back. So let's jump into gender disparity in sexual health counseling of cancer patients.
Well, you've got the expert right here. Let's jump into it.
The expert. Okay, let's jump in. So listen to this. In recent years, studies have revealed a startling disparity in how the medical sciences treat men and women. Most studies looking at different ailments and how to treat them involve men, which means that physicians often aren't as well equipped to deal with female issues compared to male health issues. One of these disparities is reflected in how cancer patients are counseled about the sexual side effects of cancer treatments. Recent research efforts have uncovered significant differences in how male and female cancer patients receive counseling. In fact, the study found that most female cancer patients do not receive counseling about the potential sexual side effects of treatment once they begin cancer treatment. This is despite the fact that plenty of women tend to experience high rates of sexual dysfunction during cancer treatment, with 90% of women experience sexual dysfunction compared to only 6% of men.
Wow.
Only 1 in 10 women were asked about their sexual health while undergoing therapy, while a whopping 9 in 10 men with genital urinary cancer were asked about their sexual health.
Okay. May I jump in here? Now that
Absolutely.
we have a meritocracy here. All right, there's a lot of things that are wrong here.
This is a lot to unpack.
Yeah, there's a lot to unpack. And for once, I'm going to go against my gender and say that, something is rotten. They used to say something is rotten in Denmark back in the day, but I don't want to offend anybody that's from Denmark.
Yeah.
Danish here. So there's something wrong here inherently. So if we look at the study itself, one of the things that was pointed out is that during the clinical trial, men's sexual satisfaction after was one of the things that was brought up during the clinical trial, meaning it was a question and it was a follow-up item. So it was part of the trial and it was part of getting this treatment accepted. That was not the case for the woman's treatment. And if we look at it, it's pretty much the same thing. We're talking about a brachytherapy treatment for prostate cancer and for cervical cancer.
Right.
So it's pretty much the same thing. I realize there are some gender differences.
Of course.
But it's the same type of treatment, same modality, more or less the same side effects. Yet, during the clinical trial for men, there was no stone left unturned, and there were a lot of follow-up questions as to sexual health. For the clinical trial for women, wasn't even a question. It was like question number 40 or something like that, had absolutely no relevance. So right away, we start with a problem. You want more?
Of course.
Okay, then here's the second problem. For women,
go ahead, P.T. Barnum.
That's right. Do you want more? Okay. All right. Men, we are very lucky that there are a lot of treatments for some of the problems that come in. There's obviously Viagra and Cialis that's given to you afterwards to help your function. There's implantable devices, there's outside devices, inside devices. There's about 4 or 5 different solutions that's offered to a man during the aftercare. And I happen to know because I just had a close relative who had prostate cancer, and he's almost 80 years old. And he was laughing that he was being sexually counseled, and he was basically saying, like, doesn't this doctor know I'm 80 years old? I go, nah, man, come on, you can still. He's going, no, they're offering me all this stuff. So I told him, well, take it and give it to me. And then he said, absolutely not.
No, you didn't.
He was honest. Maybe I did. I don't know. I'll take the 5th on that one. Anyway, the point I'm trying to make here is that men get or have the access to a lot of things to enhance their sexual performance after some of these surgeries, procedures, and things like that. Women, who I hear crickets, I think, without being too graphic here, basically the only thing that's given to them is, here's some lube. That's it. That's all that's
if that.
If that, and it's suggested, it's not prescribed. Because another thing is that because you have this procedure as a man, you get all this stuff as part of your insurance. So you get it for free. If you're a woman, crickets, nothing. It's sort of like, oh, okay.
Well, so the article continues and says that according to researchers, physicians tend to discuss male dysfunction more often because there are more treatment options, like you just said, for patients with prostate cancer, while cervical cancer has limited treatment options. Men also have access to more tools or resources, such as implants and medications, that can help them beat sexual dysfunction. They also say that this disparity may be because doctors are likely to be less comfortable discussing sexual health with female patients. Now, this is the part that I'm interested in because I looked up, I was curious the percentage of female urologists. Women urologists represent 10% of the
Yeah.
urology workforce. If it's only 10%, then that makes sense that a male urologist would feel uncomfortable talking about, you know, sexual health with a woman for a number of reasons. But bigger than that, the idea that women are not sexual creatures, I think is the larger issue.
Yeah.
In my mind, that, well, you know, once a woman is a certain age, she's out to pasture anyway, and she doesn't need sex, and she's not a sexual person. She's past her reproductive years, and that's that.
No, and you're absolutely right. And I'm gonna go back to the numbers in a minute, but I'm gonna just point out that this is a process and a procedure where you usually have lots of years of life afterwards.
Right.
These cancers are not death sentences.
Right.
And they usually happen, you know, to men in their 50s, maybe 60s, where they still have some I'm not going to call them reproductive per se, but
well, no,
some
reproductive, because
let's call
a man can give, you know, can father children. Way, look, Tony Randall was 70 when he had a child. I mean, you know,
the more money and the more famous you are, the longer that lasts. But at the end of the day, I think we're at productive years. I think functional years. Let's call them functional years. So in both cases, there's a lot of functional years left to both cases. However, they pretty much take the women and ignore the fact that these things exist. There's no aftercare. It doesn't even get brought up. And this is the point that you made that I want to kind of talk a little bit about.
Yes, please.
The patient funnels come in two ways. With the men, it's typically the urologist that, as you said, as you correctly straightened it out, 90% of them are male. That's the pathway for the men. The pathway or the funnel for the women comes from the OBG, which in many cases is female. There are more female OBGs than male. Those are the numbers. Now, what happens is once you're diagnosed with the cancer, you get funneled into the same pool, which is the oncologist. And that oncologist, even though there's a high percentage of females, and by high, I mean relatively high, 60 to 70% are male.
Yeah, that's still not enough.
Okay. So now you're starting to see where that disparity.
By the way, these numbers are all over the place. Some say it's about 30%. Some say it's 40%.
In terms of what?
In terms of the ratio of female urologists to male urologists. These numbers are all over the place. Well, this is just a cursory research.
Yeah, in terms of urologists,
JAMA says 30%.
Yeah. Basically, from the list that I know of, from the AMA list, that we have about, it's not quite 90, but it's over 80% of male on the urologists.
That makes sense. That tracks.
Yeah.
I might just be reading
that's per JAMA. That's per JAMA data. That's a few years old, not that old. I think it's changing. I think if you go back, I know because I was in the field many years ago. And it was a very, very heavily male-dominated field. Women urologists were far and few. I've been to the AUA convention, and you wouldn't see one. And that for years and years that happened, and then all of a sudden, around 2005, 2010, bingo, there they were. In terms of that. However, getting back to the thing, I don't think it should be that women treat women and men treat men. I think that's kind of kindergartenish here. I think you as a healthcare professional have a responsibility to treat either sex. And
I agree with that, but we're also dealing with people, right? And so
I think it's part of the doctor's training. Maybe there should be, and that's kind of the conclusion that the article in the study said, that there's a need here for retraining, and there's a need for more sensitivity training, and it's not a taboo. The doctor should, if you're a male doctor and you're dealing with a woman and she just had cervical cancer and you're giving her, her follow-up and the post-op and all this, you were a surgeon and her oncologist and the person that's caring for her, you absolutely have to figure and take into account her sexual history. And I don't think that's done. And her preferences, and this is what's going to happen, and give her some counseling. None of that is done.
Okay, in 2019, there were 90.1% male urologists and 9.9% female urologists. This is from JAMA Network.
Right.
Okay.
And that's
So let's go with that.
Yeah.
Okay. So
that's where my numbers were, about 90%. I'm telling you that 30 years ago, they were far and few between.
And they're also saying that they're an aging population.
Yeah.
That may also be part of why they're not having these discussions, because of the age and the discomfort with having these kinds of frank discussions with a woman. Also, I suspect there's probably aside from the blushing part, I suspect there's a little bit of self-preservation, just in terms of like, I don't want her to construe this conversation as me coming on to her, or that I'm interested in her sex life. I don't want to embarrass her. There just needs to be some way that this becomes part of the regular routine cancer aftercare. Period. And that's the problem. There's a relatability factor, obviously, man to man, where that's gonna be sort of top of mind because you're a man, you know how this thing works. But as a urologist, you know how this works for women as well. And so there needs to be more of a normalization of women's sexuality. I'm not sure when that's going to happen. Maybe the urologist population needs to get younger. I'm just not sure how to fix it. You can't make people comfortable.
Again, I do know the numbers here, and unfortunately, the numbers about the average age is about 55, and that's cool. And again, I don't want to be ageist.
Really? Because
I'm up there.
Patients are getting younger.
55 is young compared to me. But
I'm saying just in terms of the sensibility.
But even though I'm a decade older than that, I don't think I'd have a problem talking to somebody and all that. But then again, I'm not in front of that patient, and I'm doing it in my mind and all that.
Yes.
What happens when that person is in front of me, and what am I going to say?
It's always easy being a Monday morning quarterback, right?
Yeah. Oh yeah. Of course you should say that, and then you're confronted with the person, and she's distraught, and am I going to add more misery to her? And then at the end of the day, there's really no pill, no gadget, no nothing for the woman. I mean, that's another problem that we have.
Now, let me ask you this. What do you think if there were, say, for example, in cancer care, there are resources like there's a person that you can speak to, etc., outside of and they're part of the team. They're part of the
community
cancer
oncology team, the PA, the NP.
Right. What if there were more people like that? Do you think that would make a difference?
I'll tell you.
That's their job, is to just have these conversations with patients.
Yes, and from what I hear from talking to oncologists, and more importantly from talking to my friends who unfortunately had cancer, when they get that diagnosis and they're being told, and the doctor's going through the thing, it's pretty much like that stereotype of that movie where the person's talking. The mouth is moving.
Yes.
And these are the people that have talked to me are like, lawyers, people who are litigation lawyers, or people who are been in the front lines of whatever. And they say that when that diagnosis hits them, it's just like mind freeze. It's like things go in one ear and go out the other.
Yes.
And it's almost like their light flashes before their head. And saying it at that point, and having your doctor checklist, I don't think it's enough. I think that, as you correctly again said, there has to be some community, and by community I mean the community of care.
Right.
Some community of care involvement. There has to be proper handouts. There has to be a care program that takes into consideration, this is a person who's going to be alive for the next 25 years. What are we going to do? Or 30 years. The life expectancy after this on an average is at least 2 decades. So what are we going to do to help this person live those years in a happy manner.
I wonder if maybe as part of the paperwork, just like they ask you about, the try to determine the financial toxicity of treatment, maybe, an option. Would you like to discuss sexual health options after your treatment? And check yes or no if it's something important to you.
I think you bring it up. I think you bring it up whether
People are
care.
embarrassed about, and also some people feel vain talking about it. Some people feel embarrassed talking about it. Some people feel shy talking about it. I think it should be the woman's choice and the man's choice.
I'm telling
I mean,
you that
your relative was obviously very uncomfortable having that discussion, mostly because of his age.
He was uncomfortable at 80, but you know what? He didn't have a problem bringing it up with me and asked me all the questions. It's just like the setting and the time.
Mm-hmm.
And then when he went for like round 3 with the doctor, he did have a lengthy discussion about the side effects and the prostate cancer and what to expect and what happened 6 months afterward.
That's your question. Is your relative sexually active?
Not at this point. At this time, he's a widower.
Okay.
So at first he goes, but then after thinking about it after a while, he said, it's like, it's always good to know your options. He wasn't planning on doing anything, but it's always good to know your options.
Right.
And to know that, that things can happen. And that science can help things happen. So that was that. And I think the conversation with me helped, because I said, I was joking when I say, well, get the stuff and give it to me. And then he pretty much said, is it that good? And I'm there like, oh yeah, man, get all that stuff. Just send it over to me. So,
and what kind of stuff did they offer?
I'm uncomfortable discussing that type of thing, but honestly, it's
okay.
All right, you know what? I'm only kidding.
All right.
I'm only
kidding.
Because
seriously, if you're uncomfortable, then we won't discuss it.
But
I am curious.
They give you 3 types of options. Option A is, the little blue pill, the little yellow pill, and chemical intervention, chemical stuff, and take them and then see what happens, type of thing. So they offer that.
Okay.
I mean, that's the front line, the cheap line, the front and cheap. Then the other one is a whole
incontinence.
Well, those don't cure the incontinence.
No, I know they don't cure the incontinence, but that's a big issue as well.
We're talking about sexual. The incontinence
yes, I know.
they give you the diapers and good luck.
Really?
Yeah.
Well, you might piss your pants, but at least you'll be able to get rock hard. Yeah. That's ridiculous.
Yeah.
That's ridiculous.
Then the second line of defense is they give you like rubber bands and all that, like a set of rubber bands and stuff that you put on them. I'm not going to get into that too much over the air, but you can use your imagination.
No, I really can't.
Well, you kind of put a rubber band on it after you achieve erection, and it kind of keeps you that.
They offer that?
They got those.
No way.
Yes way. Again, whoa. I said, dude, get some of this. And then the third line is some device there's implantable devices and things like that.
Oh wow.
Which I think is just like too ridiculous.
Wow. And this makes care for women seem like the dark ages.
Oh yeah,
we've got all these options.
I wasn't kidding when they give you a jar of lube and say good luck. That's basically what the woman
Do you
gets.
know a woman that's happened to?
No, because they don't even it's just insurance.
It's just a jar of lube.
I know it's not covered under insurance.
Okay, but how do you know it's a jar of lubricant?
That's all they have.
Are you making that up?
It's.
Are you making that up?
40% made up. 40% made up.
Oh my
60% made up.
He's making this up. So you have no actual knowledge that they hand a woman a jar or a tube of lubricant. You don't know that for sure.
Well, they. Okay. I know that.
I heard it
okay. No. You know now. You see now I have to defend myself. The number one symptom is vaginal dryness.
Okay.
Okay, that's the number one symptom to this procedure.
Okay.
And
so you're
the output.
extrapolating. So you're extrapolating.
Okay, that's the biggest problem. So if you're experiencing that, there really hasn't been a lot of drug therapy
right.
for that. The only real therapy right now is some sort of lubricant.
And it just feels like it's just in relation to men,
Now,
not in relation to women
I
at
will
all.
say this.
Because there's also, I imagine that, and I don't know this for a fact,
Yeah.
but I imagine that if you go through a procedure like this, there's a loss of sex drive. So this doesn't really deal with the lack or loss of sex drive.
I think the way it's been explained to people, and from my knowledge, again, I'm not a doctor, so I'm going
Of course,
into
right.
some areas, but again, this is like 70-80% informed. You just had a traumatic experience, you, in terms of the cancer, therapy, all of this, you probably had a traumatic experience in terms of your pocket.
Right.
You're being offered things that you never really considered. And
well, you never considered them because they don't really talk to you about this beforehand.
Well, yeah, and also it's a progression, because for the first 5 or 6 months, it is very difficult to be active. But then all of a sudden you start to heal, you start to feel better, you paid off your bill or whatever.
Hopefully.
And now you're back to business as usual. Like I said, you have a long life after that.
Right.
So now all of a sudden you're sitting there in a chair 6 months later, you're feeling good, and you say, hey, maybe it's time that I started exploring other options. Now, if you're a man, it's covered under insurance.
Right.
You get all this cool stuff, and you've got options.
All these goodies.
Or, you got option A, B, and C. I mean, there are nut jobs, sorry out there, but that's what I'm going to say. They go for option C, which is implantables and devices and erector sets and all that. Oh, this is going to get flagged. But anyway, it literally is. It's the device that you press a button in your thigh, and all of a sudden you can perform.
Wow.
But all these things are yours to explore. What happens is that the woman, they might give you an option, but you got to go to the store and buy it. It's not covered by insurance.
Well, what option is there other than, like you said, the lubricant? I can't think of anything.
That's about it. The pain of the lubricant. And at the end of the day, it's like, what can you do?
That's unfortunate.
Yeah.
And that's unfair.
It's not good. And it wasn't part of the clinical trial, because sexual satisfaction afterwards have not been part of the clinical trial. And because it isn't part of the clinical trial, it's not part of the counseling or the pre-counseling.
Right. That's what I was gonna say. I was gonna say I'm pretty sure it's not part of the pre-counseling either.
Yeah.
Research is gonna have the research community is gonna have to do a better job. Gonna have to step it up.
Yep.
Go to urbanhealthtoday.com for the links and coverage of these articles. And remember, you only have one life and one body, so you got to do your best to make it count so your years are full of life and full of health. Information equals transformation. So small steps each day, people, and you'll see a difference. I'm sure of it. All right, that's all we're going to do for today.
Bye, everybody.
Take care. Thanks for listening to Urban Health Weekly today. I hope you'll join me and my friends next week so you can stay informed and inspired to take control of your health. See you next time.